And if we can get a patient a tumour which is chemosensitive and given chemotherapy, we can see big results in the size of the tumour after chemotherapy, so the Ewing's and the fibula, pre-chemotherapy, post-chemotherapy, a much easier surgical resection. It's another typical case where we would use preoperative chemotherapy or neoadjuvant chemotherapy. There's an osteosarcoma in the bottom of the thigh bone. Very interestingly, this is a typical X-ray that we see. X-rays are very poor at actually showing tumours sometimes. And it really is, the MRI scan has been a big help to us in actually working out whether the patients actually have got sarcomas. This is our stable horse really, our workhorse of how we reconstruct these legs and these arms. And this is a big knee replacement that you can see, called an endoprosthesis. And we use them quite a lot. They're useful ways to reconstruct a limb, but they do fail. You're putting bits of metal into bone, and these are young patients who are going to walk on them and do quite active lives with them. And so unfortunately, probably their life expectancy is about 10, 15 years. That is even less if they get infected. And joint infection and prosthetic infection is a big problem in orthopedics. On the whole, they probably function about 80% of normal, so they're pretty good. And this is an example of a patient who actually has got a complete thigh bone replaced by metal. So he's got a metal hip, a metal knee, and in there. He skis, he jet skis, and he's got a pretty active life, but a little bit wobbly on there where the muscles haven't quite attached to the bone. But on the whole, these patients do pretty well with these endoprostheses. But the big concern really is that these are a number of endoprostheses that are done in different sites of the body. This is data from the Birmingham unit, that there is quite a high risk of infection in some people, the pelvis here, and endoprostheses in the tibia. So working with our plastic surgeons, we try and avoid using endoprostheses if we can. We prefer using biological techniques of reconstruction. This is a typical scene in an operating theatre where you've got an orthopaedic surgeon taking out a sarcoma, and you've got a plastic surgeon preparing to reconstruct. This is the only intraoperative picture I've got, so I'm going to pass over it quite quickly. And this is a patient who's got a big tumour of the pelvis, and when we take out this, we're going to have no join between the spine here and the hip joint. And so what the plastic surgeons do, they take out a bit of fibula on a vascularized pedicle here, and then they plumb it in using microsurgical techniques to rejoin the hip joint to the spine. And after 2 years, you can see how that's hypertrophied. It's almost come like the bone it was, which is called the ilium. And so this has made a big difference on this guy's ventral function. If you didn't have this in, he'd have lots of pain and he'd have a short leg. These plastic surgeons do think quite laterally. It's another case that they took on. This is unfortunately a young girl who had a tumour down here in the bottom of the ankle, in the fibula. And you've got to take that out, but the reconstruction will probably be what is called an ankle fusion, where you would actually stop any movement in the ankle joint. An 18-year-old, that's quite a thing to say to an 18-year-old. But actually this is what she got, pretty good function in the ankle. And how they did that was, once they took out the bottom of the fibula, they realised that there was a fibula at the top of the leg, which wasn't being needed. And so they just took it out, turned it over, and used that to become the new ankle joint. And that's what I find is sort of, it's breathtaking ideas that you get from working in a specialist centre like this. Another sort of quite interesting sort of reconstruction, which all comes from working in a specialist orthopaedic hospital, is the tumour of the tibia, which, it's relatively easy to take it all out. But when you take it out, you've got this big hole, and this patient was young, and if you put a big bit of metal in there, that will probably need changing every 10 years. There's a high chance that eventually you won't be able to change it anymore, and amputation will be needed. This is something called an Irizarra frame that one of my colleagues, Martin McNally, uses all the time, and he does a technique called bone transport, where he breaks a bone at the top of the tibia, transports it down slowly, a millimetre a day over about a 6-month period. And in the wake, I don't know if you can see the bones being formed. So finally, after the frames come off, a whole new tibia has been formed. And all the young girl has got to show for it is some scars in the skin where the wires have come down. And so that girl is cured from the disease and has got a well-aligned, normal functioning tibia. So, and when we use that technique probably twice, 2 or 3 times a year. But on a slightly more sobering aspect, I wanted to talk to you about survival in our specialty. And on the whole, half our patients with high-grade tumours will not live past 5 years. But if you break that down even more, it gets even more sobering. If a tumour is under 5 centimetres when it presents, actually survival isn't too bad. But anything over 5 centimetres, survival really tells off that you're unlikely to survive if you present with a sarcoma over 5 centimetres. And this is some data from our local unit in Birmingham, which was the average size of presentation of their sarcomas, and it's 10 centimetres. So a lot of sarcomas are well over that 5 centimetre size, hence why survival of these is so poor. Unfortunately, we see patients with enormous sarcomas which need pretty mutilating surgery to control. Once they get that big, it's quite likely that micrometastases have occurred, and so 6 months later we're seeing a chest full of disease, and I'm afraid once that's happened, patients do die pretty quickly. So I use every opportunity I can to try and educate GPs, other orthopedic surgeons about the early presentation of these cancers, these sarcomas, to get them up to us quickly, and that's got our best chance of getting one of our best chances of getting their survival better. These are just some sobering figures about the average delay that patients with symptoms have before they're diagnosed in a tumour centre with osteosarcoma, Ewing's, and Ewing's in the pelvis, but also tumours there can hide a little bit easier. So there has been some guidance about what to send up to us in Oxford about sarcomas. And this came out of the Department of Health in 2000 about sarcomas. If they're any lump that's deep to fascia, greater than 5 centimetres, it's painful, increasing size, should be sent up to a tumour service. But in our practice, we see lots of sarcomas that are superficial to fascia, that are luckily are under 5 centimetres, are not painful, and actually don't increase in size that readily. And so we don't think that's great guidance. And so I like the concept of the golf ball, which a colleague of mine, Bob Grimer, has popularised. That a sarcoma is a sarcoma, anything bigger than a golf ball at 3 centimetres is a sarcoma until proven otherwise. And we're very happy to get these assessed with either ultrasound or MRI imaging. And we try and get that message out to as many people as we can. So, overall treatment survival of people with bone tumours, osteosarcoma and Ewing's. Before we started using preoperative chemotherapy, their survival was very poor. And in 1970, chemotherapy came in. And it's a concept that it's a systemic disease trying to mop up those micrometastases. And that's called neoadjuvant. And now we're seeing 67% 5-year survival. So tumours, osteosarcoma that we can treat with chemotherapy, we're getting pretty good long-term survival on. Unfortunately, in tumours like chondrosarcoma, where we haven't got chemotherapy to give them, it's relying on surgery to get the tumour out, and it's not being able to treat those micrometastases. And so survival for the big, high-grade sarcomas is very poor, less than 10%. So what we'd like to do is have a systemic treatment to treat all our sarcomas. And at the moment, we haven't got it, but I'll talk to you a little bit about how we're developing that. In soft tissue sarcomas, again, we really haven't got systemic treatment unless patients have got metastatic disease and we're giving this in a palliative capacity just to try and prolong their lifespan. And then if they have that, they have an overall lifespan extra about 10 to 12 months if they have chemotherapy. You can see with high-grade soft tissue sarcomas, we're really only curing 20 to 40%. And this is slightly against what's happening generally in cancer. This is a graph of a number of different cancers, the common cancers, the top 28. I won't go through all of them. You can probably see there's over the last 40 years, from 1970 to 2010, there's there's on the whole a better survival in a lot of cancers. There's down here is a little bit static, but most cancers with more systemic treatment, such as hormonal treatment in prostate, breast cancer treatment, they're seeing a much improved survival. But sarcoma on the whole has stayed pretty steady at about the 50% mark. We haven't really seen those improvements. But what we have seen is we've seen more evidence that actually it's the DNA and a problem with the DNA that is powering these sarcomas. So what happens is that the DNA in the cells of the bone or the muscle gets a problem in the DNA, and that DNA is going to code for a protein which is going to power that cell to switch from a healthy cell, a happy cell, into an unhappy cancer cell and start proliferating without any control. And there's been quite a lot of interest in genetics of sarcomas. Particularly, we've seen a lot of our patients actually have a syndrome called Lee-Fournier, where a lot of our patients have sarcoma, but also maybe have a breast cancer, or they've got relatives who've got a colon cancer. And they actually have a genetic abnormality which means that a p53 suppressor protein that tends to control cells is lost. So they don't have that inbuilt control of cells, and so these cells are much more likely to get out of control and become cancerous. And we're seeing a lot of our tumours, we're seeing definite genetic mutations. This is a gastrointestinal stromal tumour which has got kinase mutations. We're seeing specific translocations between different chromosomes. Bits of one chromosome appear on another chromosome in Ewing's, synovial sarcoma, rhabdomyosarcoma. So we're seeing lots of different genetic problems which are causing that cell to lose control and become abnormal. And this is just to sort of talk to you about really that's where sarcomas have got to go. We've got to start thinking at the genetic level, where the chromosome, the DNA, produces these proteins which become a molecular machine which turn a healthy cell into an unhealthy cell. And just to sort of finish, I know this is a slide, yes, this is probably a difficult diagram to appreciate, but in a cell, this is a cell membrane, this is a DNA here, there's lots of these different pathways. So there's these things called ligands, which are proteins come onto receptors, and these cause pathways within the cell to actually affect the nucleus. And there's a lot of work being done in various cell biology centres around the world to actually work and map out what these different pathways are. Normal adjuvant therapy, the chemotherapy I talked about, literally kills the cell dead. It blasts it away. But unfortunately, there's lots of collateral damage. And that's why you see patients like chemotherapy who lose their hair and they get diarrhea, etc. Because normal active cells are also affected by chemotherapy. So the cell's blasted to death. To try and reduce that collateral damage, we're getting these new targeted biological therapies which are working on these different aspects of the pathway in the cell. So we're finding we've got antibodies that can close up the receptor here and stop pathway going into the cell. We're finding that we've got proteins that can actually block the movement of these second messages in the cytoplasm. And we've also got some compounds which can actually quarantine the nucleus where that rogue DNA is to stop it replicating and causing the power of the rogue cell. So rather than blast the cell to death, what we're doing is controlling the cell. And there's much less collateral damage as a result. And these are just some of the pathways. We're stopping new sarcomas like to get a blood supply, and we've got some factors here that are actually stopping sarcomas get a blood supply, which often we see actually evolution of the sarcomas if these treatments are given. We're seeing controlled cell death by antibodies against human necrosis factor, and we're seeing the signalling being disrupted within the cytoplasm of these